So now I would like to invite Dr. Dinesh Talwar to talk to us about anterior segment management in endophthalmitis. When a patient of endophthalmitis lands to any surgeon, the first step in any surgical intervention is to clear the anterior chamber, which may be a very tricky situation. And Dr. Talwar is going to take us through a series of cases to show how best clearing the anterior chamber can be done, which very often can be the even eventual step which may be needed. Dr. Talwar.
Thank you, Ritesh. Actually, this talk is more about how retina surgeons should approach the vitreous from the anterior segment. So it's a little more tilted towards the posterior segment surgeon than the anterior segment surgeon. Well, the key to any successful surgical management is good visualization of the field of operation, and as already been discussed just now. And the way to a successful vitrectomy is through clearance of the anterior segment. We know exogenous endophthalmitis starts from the anterior segment, then goes progressively deeper into the vitreous cavity. So if you want to do a successful vitrectomy, you need to make sure that the anterior chamber is clear, and that can be done right from either from the limbal route or from the vas planar route. And then you go ahead and complete the vitrectomy, do an IOL removal if required, and if it's obstructing your view. Now, what are the advantages of the limbal route and the disadvantages? The basic advantages, and that's where the anterior segment surgeon always prefers to go from the anterior route. So also the recent, the new vitreoretinal surgeons, because initial training is always in anterior segment. It has an easy entry, it's more maneuverable. But what is the disadvantage? The main disadvantage is the cornea is already edematous. And so when you enter from the limbus, you have a friable wound which is created over there, which may require suturing, and then the suturing is tough because it cuts through. The leaking of the wound is especially important because it causes hypotony during your surgery, and your surgical manipulations and any scleral depression becomes very difficult to do. So this is just to show you a limbal approach to anterior segment management. As you see, the entry of the infusion cannula is made first. The ports are made first before you make any opening in the anterior segment. And then now here, of course, it was decided to remove both clear the anterior chamber and also the IOL. But one thing you will see when this is being cleared, you'll see that what looks like just white cornea and infiltrated cornea. When you start clearing off, you see this is a layer of exudative material, and you'll see over here how it starts coming out. You can see it's coming out from the lower part over here. It's got cleared, and now as the IOL was removed, the rest of the membrane can also be cleared from the anterior segment first, and that makes visualization of the posterior segment easy, which is what you're seeing here. You see this fibrinous membrane is almost always there. And actually a lot of visualization problems that you see and no glow and all is because of this, especially in exogenous endophthalmitis. So keep this in mind. This is another, sorry, this is the same video. Yeah, this is another one. Now you can see again the fibrin membrane coming out, this being taken out from the limbus, and once you remove this, the vitrectomy becomes easy. Actually, a lot of visualization issues are because of these anterior segment membranes, and this is what people fail to realize. But when we were doing conventional vitrectomy for endophthalmitis, we decided I don't want to approach the anterior segment at all. So what you see over here is, now you can see this again, extremely dirty anterior chamber full of exudates, and here if you look carefully, we are using this vitrector to make a PI in the upper temporal region. Look carefully over here, and you'll see the cutter movement start over here. Once you see this, the cutter movement has started, and this completes the PI. And after you've completed this PI, you can actually clean that fibrin from the anterior segment from this vas planar route. even if some bleeding does occur, because it's very engorged with iris, it actually settles down very easily once, because the pressure is being maintained. It just clears off within a few seconds. You just continue the procedure. You don't need to do any diathermy or anything in these cases. And you can see again, this is a very, very thick membrane. This particular case actually had a very thick and sticky membrane. And yet we were able to clean up the entire thing, as you will see over here. And once you clean it, you will realize how clean the posterior segment is. You know, because it's an exogenous endophthalmitis, everything's gone from anteriorly. And the anterior part is worse than the posterior part, unless, of course, it's a very severe endophthalmitis which has gone up to the retinal surface. And you can see over here, this is getting cleared up. And the bleeding will also stop in the process. Now, you can see once you remove the membrane, or you also wanted to remove the sticky exudate from the from the iris surface, and I'm using this MVR to tease it off. And despite being extremely sticky, most of it, at least 90% of it, comes off, and you can complete. After that, you can see that behind you're seeing almost like a jet black pupil, and you know you can do that vitrectomy very easily, which is what is going on over here. No, it doesn't. You need an MVR to engage it. When you engage it, you'll see it's all the way up to the angle, and it separates out from the angle all the way up. And then once it's separated out that much, then you can use the cutter to cut it out. Sometimes you may have to go from the other side also and tease it out from that side also. So here, because it was very sticky, I used the cutter to actually cut it out. You can see this entire iris cleared up. Because this is infected. This is all infected material. You may do any antibiotic. With this so much exudation, so much infection, you'll get a recurrence. You want to remove as much of the infection as possible. And this is easily removable. It is not something which is difficult to remove. And then you do need to remove as much, because actually when you remove it from the angle, then only you get this pupil thing also clearing up. The whole thing comes off as a layer. Otherwise, you are stuck, and you may end up cutting the iris if you try only to remove the central area. Now, once this is done, and if you still have a hazy media, then keep it in mind, there is always epithelial edema, and debridement can result in a clear view in a majority of cases. It's very rare for stromal edema to be because of the haze, and in that case, the last resort is to use 50% glycerine, but I have not found it necessary. As Hemlata showed, despite stromal edema, the vitreous can be cleaned up. You can do an adequate vitrectomy.
So can we finish?
Yeah, this is the last slide.
Yeah.
A clear view is a prerequisite for successful surgery, and appropriate anterior segment management is the first step towards the same. So, ladies and gentlemen, that's the way to go. Thank you very much.
Thank you, Dr. Dinesh. We will not take any questions because we have the next talk from our instructor, and that will interest corneal surgeons. Actually, once you are doing a DSEC, you want a pressure of 60 millimeters of mercury to stick the lenticule to the cornea. And what I have seen is anterior segment surgeons, what they do, they press, they see the eye is hard. There is no calibration to see whether there is no calibration to measure what is the actual pressure inside the eye. And you have to maintain a pressure of 60 millimeters for 10 minutes to stick the lenticule. So what we have done, we have used a vitrectomy machine where you have an infusion pump where you can monitor on the vitrectomy machine what is the exact pressure. You enter into the eye with a 30 gauge needle and increase the IOP to 60 for 10 minutes. You keep the IOP at 60 millimeters for 10 minutes, and then you don't, and what corneal surgeon do is they press the posterior lip of the paracentis to decompress it. And many times during decompression, what happens, more of air comes and they again refill it. So here is a technique. He'll show one video where we have used a vitrectomy machine to monitor the intraocular pressure. And we reduce the intraocular pressure to 20 millimeters at the end of the surgery, and we don't need to decompress it.